number of randomized trials have shown that maintenance therapy is of value with respect to progression-free survival for a majority of our patients. Specifically, a meta-analysis recently described that overall survival could also be improved if all of those studies were grouped together. Thus, in the United States at least, use of lenalidomide in the post-transplant setting has become quite common, although there remains some controversy due to the cost and due to potential side effects. In this case, this lady had high-risk myeloma, I think justifying even more the use of maintenance therapy, which in this case was lenalidomide alone, but in retrospect could have perhaps contained other agents. For example, the use of bortezomib is sometimes recommended for high-risk patients, often given subcutaneously every 2 weeks as first described by the Dutch in one of their large randomized trials. The use of long-term proteasome inhibitor, particularly bortezomib in this case, has been demonstrated to overcome some of the high-risk features such as we saw in this young woman. A patient like this is at relatively high risk for early relapse, so we would recommend follow-up at least every month, 2 months, or an extreme if she was very stable every 3 months. But generally speaking, because of the risk of relapse, because the patient is still on therapy, I would probably see this patient myself every 2 months. This patient has developed a biochemical relapse but is still working with good performance status and no signs of end organ damage. Traditionally, one would be safe following this patient for some period of time until there was some signs of impending problems. However, more recently, I think our approach has been to intervene earlier. This is because we have many new drugs which are available, which are actually, if anything, more effective than the drugs that this patient received at her initial therapy. So my own bias is to treat early and not wait for problems to emerge. There are multiple options for treatment of this woman who has experienced a biochemical relapse but with good performance status and normal renal function. The one drug we might want to change is lenalidomide, since she's already progressing on that drug, and escalating the dose is not often that effective. We have multiple new choices. Last year there were 4 new drugs approved by the Federal Drug Administration in the United States. They include carfilzomib, a proteasome inhibitor, ixazomib, an oral proteasome inhibitor, elotuzumab, a monoclonal antibody, and recently we have seen that the drug daratumumab is powerful and effective in these patients. In this particular case, I think we should still be aggressive with her care. She has high-risk disease. She is progressing relatively quickly despite maintenance after autologous stem cell transplant. In this situation, I would personally turn to our most potent and most effective drugs, which are the proteasome inhibitor carfilzomib, which is the most rapidly acting and produces the deepest response, and I would escalate her immune modulator therapy from lenalidomide to the drug pomalidomide.